Okay, good morning again, dear Mr. Chairman, dear ladies and gentlemen, colleagues. First of all, let me express my gratitude to organizers of this meeting and the kind invitation by Vasilis Kotsis, good friend, and it's a nice opportunity to be here again in very beautiful place of Halkidiki, live. But I hope that next meetings will bring us more people here and more speakers to exchange our informations and our knowledge regarding to the hypertension. For today, I'm asked to give just a few remarks regarding the risk factor control beyond hypertension. So I'll remind you about some factors and how we are controlling them and what is our situation now in the era of the COVID. But let me start first with this slide, which is presenting data from the World Heart Organizations that we see that cardiovascular diseases are still number one cause of the death in worldwide, comparing with all the other diseases. If we look only at non-communicable diseases, there is also cardiovascular diseases on the first place. There is noticed slight decrease of the death from the cardiovascular deaths. But if we include the diabetes as one of the disease with we can say increasing mortality, more than the half of all deaths are related to the cardiovascular and diabetic deaths. Of course, during our life and during the older age, the percent of cardiovascular diseases is increases. It's a similar situation between the genders. Males are a little bit more affected by the cardiovascular death, but also there is a very high percent of the cardiovascular death in the female population. What about Europe and our region in the Balkan, because I'm coming from Serbia? As you can see, there is a slightly decrease from the cardiovascular death in most of the European countries in the past decade, but there is also very heterogeneous data from our region, from the Balkan region. So some countries are very high cardiovascular death, and there is improvement because of the lot of activities by the national societies and the health organization in these countries. Anyway, if we go further, this meeting is related to the hypertension, diabetes, and other very important risks for cardiovascular disease. As you can see, blood pressure is still a top number one cause of the death. High blood glucose is one of them, and obesity is in the top 5. So this meeting is related to the 3 of the most common causes of the death worldwide in the populations of humans. Situation is similar everywhere in the world. So high blood pressure is everywhere the number one cause of the death. And also, as I said, some other risk factors such as obesity and diabetes are also playing important role in this data. But anyway, we are just talking usually about what is happening with the patients who has a coronary disease or have some cerebrovascular disease, but this is only the top of the iceberg. All these factors or all this, what we are related this meeting and consequences of these factors are bigger, play a bigger size what we are not see, and all this together are make this heterogeneity and on the end causing some complications on the organs which are affected by these factors. If we now go further, and I will show you some data from some registries and from some studies what was performed related to the hypercoronary patients and some not coronary patients. This is data from EuroAspire study where the most countries participate. Between all of them was in Greece. So if you look at what has happened with the coronary heart disease patients, you can see that the hypertension is present with 79%. Also, the obesity is 42% among all these patients who was included, and also there is a high percent of them who has dysglycemia or not regulated diabetes or not diagnosed diabetes. This data from EuroAspire shows that in the past 2 decades there is increase In obesity, there is increase in hypertension, and also there is increase in diabetes. More and more patients are, every time when we do this research, are affected by these three factors, or we can see there's three diseases who are very important for the cardiovascular complications in the end. Some other predictions and some other scores are also predict what and how all these separate, or in total together factors can give some risk for some events, and this is one of them. And you see, if you have only hypertension, you have relatively low risk, but if you add cholesterol, increased cholesterol, the risk is much more higher. If you add the diabetes, is also higher, so you are going very high risk if you have all these factors all joined together. European Society of Cardiology gives a lot of scores, and there is a lot of different opportunities how to calculate this score. This is one from the Europrevent Society from the last guidelines. Actually, this one is for World Health Organization, sorry by that. And you can see, if you compare people who has only hypertension and has only smoking status and cholesterol, it's on the left-hand side, it's how looks this chart. But if you add diabetes in this card, you can see most of these columns are red, so those patients with diabetes has very high risk comparing with the other risk factors who are chargeable in this score. But it's not only the problem. What we notice with these risk factors during some studies and some registries, we also notice that diabetes and those who has high blood glucose are very huge number of them, and many of them are undiagnosed. So this is also data from EuroAspire. As you can see in this registry for coronary artery disease patients, 1/3 of all on the beginning of the registry was diabetic patients. But when we perform all investigations and all the steps, so we are noticed that also 1/3 of all of these who participate in EuroAspires are potentially or new diagnosed the diabetic patients. So the numbers of patients with diabetes is much more higher comparing on what we see in everyday practice. It's a similar situation when we look what is happening in the primary prevention, or only for those who are with some risk factors. Also, when you perform analysis with the glucose, you can see that in primary prevention, we detect some 16% new diabetic patients according to the OGD test, and there is also a huge number of them scoring par glucose tolerance. So anyway, some 41% of them are potentially could be diabetes in primary prevention. The second problem, what we are also fighting, and what is also present every day in our practice, is obesity. Obesity is something what is also increasing in our way of life, and I will not go through this very much, but this data is also clearly show that obesity in some European countries from the past years and from different surveys are increasing from year to year. This is how look like the map of obesity in worldwide. This is the data what is showing how was obesity in 80s and end of 80s, and this is for 2000. And there is also notice that this number of those who are obese is increasing in the past decade everywhere in the world. It's a similar situation in the urban and the rural area. So obesity is epidemic problem in all those people everywhere in the world. But also you can see that in some areas where this was, let's say, particularly low some 20 years ago, there is a trend of increasing in the both places of the living of the urban and rural areas. This is one of the interesting study what is giving us projection what is happening young people who has risk factors and who are obese or they have the risk for diabetes in the period of some follow-up of 15 years. Most of them from the beginning who has high risks, they develop hypertension, they also develop dyslipidemia, and then they develop some diseases were related for the damage of some of the organs. But for diabetes patients is also very important that they notice that many of them increase microvascular diseases and some complications of the microvascular diseases in the early beginning of our life, so in the period of young people. If we now look all this data, what we have about obesity, about diabetes, about hypertension, and from the registries, we try to do some risk model according for the data from the EuroAspire. So we recently published this, and we notice what are these dominant and what are most important factors on which should to be pay attention and what should to be maybe more treated comparing to the others to have the better prediction for the future for those patients. On the end, it's noticed that uncontrolled diabetes is one of the risk factors. Also, dyslipidemia is one of the factors. Low GFR is one of the factors. And what was surprisingly and interesting for us that doesn't matter what kind of the risk country you belong, moderate, high to the risk or very high country risk, the risks by self is wearing very high risk for some complications on the end. So if you even in a moderate risk, the predictions are not good, so that you should to be very careful with those patients who are in any of the risk. Last year was published guidelines by the European Society of Cardiology of Prevention and Clinical Practice, and some risk factors, except this traditionally what we are following and what we are every day finding in our offices, they are also noticed, and they also now recognize that air pollution, then emission of the some materials, then use of the fossil fuel, limiting carbon dioxide emission, and so on. They are the risk factors for this period and the future, with which we should to be more careful because they can increase the risk of cardiovascular mortality and morbidity. And they are also notice this score and categories associated with the cardiovascular risk. So there is now some subgroups, what we are just talking, that even those who are younger have some risk factors. They are on some, let's say, low or to high risk, despite the years and despite these, what we were thinking that in the younger period, the risk is lower. But of course, how you have any changes in organ damage or some other additional risk factors, the risk is increasing in those populations and going to the very high risk for cardiovascular diseases. Let's now move about the, because we know a lot about this from the guidelines and what are the target values and what is our goals to affect these patients appropriately and to have adequate treatment for them. But what is the situation in the practice? What target are we reach and how is our results in this field? This is one very old slide from Euroheart survey that is showing, according to the guidance, how many percent of patients are reach these targets, and you have the guidance from 2003 and guidance for 2007. As you can see, different values according to the guidance give us different numbers, but a very huge percent of all the people are out of these target values.
Sorry
Is the similar?
Professor Lovic, sorry to interrupt. You have 2 more minutes to conclude. Please.
Okay, I'm very close to the end. This is data from the Eurospire as well. As you can see, there is increase in the control of the blood pressure, cholesterol, or glucose, but we are still not reach our targets. Data showing that prevalence of the blood pressure is overall in the European country, let's say some 46%. We have a very high percent of those who are using blood pressure lowering drugs, but the control of the hypertension is almost half of all of them are control blood pressure. So what is the situation worldwide? This is the data about the control of the blood pressure in the United States. You see that in the beginning they have in 20s 31%. They then increase the control of the blood pressure almost 50%. In 13 to 14 they go up to 53%, but now they are going down and the control of the blood pressure is decreasing. One of the factors why they are decreasing is awareness. This is the data also showing that some, let's say 78% of all patients are aware of the treatment and the effects of the treatment of blood pressure control, but unaware it's, let's say 29% of all, and you have also data from different countries. And of course, older population are aware of the blood pressure control and the effect of the pill comparing with the younger people. Thus, we will improve control of the blood pressure if we add the triple combination in everyday practice, because the guidelines are now suggesting us to have combination therapy as a start. This is the data from a triumph study analysis, which shows that in the beginning, if you add triple therapy, there is an increase and greater rate of therapeutical control, but in the some period after 6 months of the start of the treatment, there is inertia between the patient, so the control of the blood pressure in these cases is going down. Let me give you just few data about one risk factors of which we have to now be very more careful, because we are still living in the era of the COVID, and the COVID didn't affect our patients, especially those who are hypertensive, obese, and with diabetes mellitus. This is data from the beginning, what is showing that these risk factors are also dominant for the COVID patients, and these groups of the patients are more affected by the COVID. If we look what is happened with some risk factors and how the studies reported how many patients with these diseases was affected, as you can see in different studies, almost 20% of all was hypertensive patients. So the second place was patients with diabetes with 10.5%, and all the other diseases much more or less than comparing with the other. Similar data is showing those who survive COVID or not survive COVID. The most of those who survive or not survive was hypertensive of diabetes patients. So these two factors we can say that is also very important for further control, because we're expecting that in the post-COVID era, these diabetes and hypertensive patients will increase their numbers, especially because we know that during this period of the COVID and during the period of the lockdown and all the restriction measurements, what was on the stage, then people are less active, they increase their
food. Please. Sorry.
COVID. Okay, this is what
it's not fair.
So we also notice in European society that these risk factors should to be aware about the COVID. And this is my conclusion for today, that we can say the control of the blood pressure is poorly implemented. There is a difference between countries. There need to work more on the diet, exercise, and to improve adherence and doctor and patient inertia regarding for the treatment. Thank you very much.